Welcome to ACS Heart. I'm Dr. Juwairia Al Aly, consultant cardiologist from Rashid Hospital and vice president of Emirates Cardiac Society. As you know, stroke is a major health problem, and there's a good number of stroke that is cardioembolic. So it's important for every stroke patient to have an echocardiogram to look for cardiac source of emboli. Most of the time you'll find the test to be normal, but if you find an abnormality, usually it's a life-threatening abnormality that is very serious and it needs to be addressed urgently. So the major concern for every stroke specialist is there an intracardiac thrombus or not? So echocardiogram, you can assess if there is a left ventricular thrombus or a left atrial thrombus. And depending on the finding of the echocardiogram, you might need to go for further testing. Generally, if the echo is completely normal, so you have a normal left ventricular function, no dilatation, and the left atrium is normal and it's not dilated, and the patient is in sinus rhythm, you are highly unlikely to find anything, any intracardiac thrombus by transesophageal echo, and that will be an unnecessary test. The other major question when you have someone a young patient who comes in with a stroke is if they have an interatrial shunt, like a PFO or an ASD, and that also can be diagnosed with transthoracic echo. Sometimes if you cannot elicit the presence of a PFO by transthoracic echo, you would need to use agitated saline injection, and you would see the bubbles crossing from one side to the other in the heart, usually with instruction of Valsalva. Now there are a few patients that you might not be able to elicit that by transthoracic echo, and in that time you need a transesophageal echo to establish the absence of PFO. Now these two are like the major things that you're looking for, but then there are other things that are smaller incidents but are also life-threatening. So sometimes you would have small masses in the heart, like fibroelastoma on the aortic valve, and these will require resection because these are the source of emboli, and that can be seen by transthoracic or transesophageal echo. And on top of that, you will see markers of atherosclerosis like you would see everywhere in the body, on the carotid and the aortics. See them in the proximal aorta, which is visualized by transthoracic echo. So these are the major findings that you're looking for. Also, depending on the patient's history, sometimes you'll be looking for vegetations on the valves, and these will be clearly obvious by transthoracic echo. Now, in the case of pulmonary embolism, what you're looking for is either finding a thrombus in transient. So generally, it's a thrombus that originated from the peripheral vasculature, passes through the IVC into the right atrium, through the tricuspid valve, and into the pulmonary artery. So if you're lucky, you might catch the thrombus in one of these structures that can be seen by transthoracic echo, or to find features related to pulmonary hypertension that the patient with acute pulmonary embolism will have. So you'll have right-sided dilatation and D shape of the septum, have pulmonary hypertension with increase in calculated PA pressure and significant pulmonary tricuspid regurgitation. So these are the findings that you would see in echo. All patients with pulmonary embolism will have a CT chest, and depending on the expertise in your center, the radiologist can actually comment on the size of the right side of the heart, so you will know if there is a right side strain ahead of time, even before doing the echocardiogram. So in summary, these are the findings that you would see in echo. It's a very important tool to be used in pulmonary embolism and stroke. And I hope that helps you treat your patients better and have patients with better outcome. Thank you.